Hello, my name is Shara Vickers. Thank you for joining me today as I discuss my proposed research investigating chromium supplementation in type 2 diabetes. Chromium is found abundantly in nature. It exists in metallic, hexavalent, and trivalent forms. The hexavalent form, however, is highly toxic. We will be focusing today on the trivalent form, which occurs naturally in food and is used in supplements as well. Interest in chromium in relation to human health dates back to the 1950s. Chromium is thought to potentiate the action of insulin, although the precise mechanism of how this occurs is not well understood. Some of the literature describes chromium as playing a role in enhancing the activity of insulin receptors and thus increasing glucose uptake. There are challenges with establishing nutritional status. Serum levels are not indicative of overall tissue status, and urinary measures seem to be influenced by recent intake, again, rather than overall status. Furthermore, there's a wide variance among food sources, depending on growing conditions, location of where your food was grown, what your livestock is fed, and even the processing and preparation of food can affect the chromium content in the food. However, with that being said, most Americans do meet their nutritional needs, or it's thought that they do, daily. Children between the ages of 1 and 8 only need a very small 5 to 15 micrograms per day. Children between the ages of 9 and 18 need between 21 and 35 micrograms per day. Again, there's some differences there if they're male or female. For adult population, again, we need between 25 and 35 micrograms per day. Food sources include, and this is of course not an exhaustive list, but they include eggs, whole grains, garlic and herbs. Broccoli is a particularly good source. A half cup provides something along the lines of 11 micrograms. Orange and grape juice and brewer's yeast. And yes, brewer's yeast does transfer into beer and wine being a source of chromium. However, that's not necessarily a recommendation to stop by the pub after this presentation. The existing literature consistently shows that chromium status is lower in type 2 diabetics than it is in their healthier counterparts. This is just a sampling of the literature here. The first study mentioned was conducted in India, and here the men were found to have an overall higher chromium status than men in America. However, there was still a difference between healthy men and the type 2 diabetic men, which is something to note. In a recently published study that looked at a Chinese population, again, an inverse relationship between chromium status and type 2 diabetes was established. This study benefited from a very large sample. It included approximately 2,000 healthy subjects, and they were compared to 2,000 recently diagnosed type 2 diabetics or those who were insulin resistant. In American data, there is a reduced risk of type 2 diabetes shown to occur with supplement use. However, when we look at the data that examines the clinical trials that examine chromium use in diabetics, the results are inconsistent. Here we just have a diagram of our typical clinical trial. Some of these studies we will be mentioning do have additional controls or additional treatment groups, but this is your general breakdown. We begin with the study population, who is then randomized into either a treatment or control group. There's follow-up, and then the results are compared. What is interesting here, and of course a bit of a concern, is that because some of the research mentioned here is initial early work, there is some inconsistency in the findings and the outcomes measured. All of the outcomes measured were relevant to diabetes. They include fasting glucose, hemoglobin A1C, insulin sensitivity, as well as fasting glucose levels. However, all of these studies did not necessarily measure or look for the same thing as a primary outcome. Secondary outcomes were also measured in some of these studies and included weight loss or weight gain, changes in body composition, as well as lipid profile parameters as well. And again, there are some inconsistencies with these results. However, let's look at the research. These again are just some selected studies. In 1997, a 4-month study involving a Chinese population showed very good results with chromium supplementation. There was a significant decrease in fasting glucose, and hemoglobin A1C levels were significantly improved in both groups of chromium supplements. Here, 2 dosages were experimented with against a control group. In 2006, Martin et al. Did a 6-month study that included that did not include an introductory phase. The entire study lasted close to a year, but there was an introductory washout phase and a phase that normalized patients to their new medication. This looked at a U.S. population and found that chromium supplementation attenuated weight gain in addition to improving fasting glucose and insulin sensitivity. Kleefstra and colleagues looked at diabetics and chromium supplementation in two different instances. The first study involved poorly controlled diabetics who were using insulin, and the second study looked at better controlled diabetics who were not using insulin but were using other drugs. They looked at a European population and unfortunately did not find that there was any difference between the chromium supplementation group and the control group. Ratchik et al. Was a short study in a European population. What is interesting about this study in particular, however, is that a good portion of the sample were not taking any medication prior to the study. They were controlling their diabetes exclusively through dietary and lifestyle measures. Again, there were some patients who were medicated in this study, but the good chunk of the population were not medicated, and here again the chromium group did seem to fare better than those in the control group in measures of diabetic outcomes. But there is a need for more work. The early trials had a lot of inconsistencies in methods and designs, so there are calls for more clinical trials of a good duration that last long enough. They're longer than the 3 months we've seen evidenced earlier, and just more consistency in the design, the control, the randomization, and even in the dosage and form of chromium being used. There's also work that's been done and is being done to better understand the phenotype who responds. Again, looking at measures of are there certain patient characteristics that respond better? Are people who have better controlled diabetes more responsive to chromium than those who have more poorly controlled diabetes? Are there other lifestyle factors? And these are things that are being examined in looking at the data, and just generally examining the inconsistencies and trying to better understand why some groups seem to show a benefit with chromium supplementation while others do not. Therefore, the proposed research here is another double-blind, randomized, placebo-controlled trial. Here we want to look again at a U.S. population, and again we want to look at well-controlled diabetics using sulfonylureas only. Some of the trials have used patients who are on a variety of medications. However, some of the research indicates that this may be a confounding factor that affects the results. So here we're going to control for that by using patients who are only using sulfonylurea drugs. The intervention group in this case will be the intervention group will be taking the drug plus chromium. The control group will be taking the drug plus placebo. Some ethical considerations with this research, and of course we take our guidance on ethics from the principles outlined in the Belmont report. We're looking at matters of benefits and justice as well as respect for persons. Recruitment for this study will be open. There will be screening. As we noted, we want an adult population, an American adult population with well-controlled diabetes on sulfonylureas only. However, it will be open and voluntary. Confidentiality will be strictly maintained. Only research staff who need to have access to data and information about patients will have access to it. All hard copies with any identifying information will be secured under lock and key. Confidentiality in laboratory results or blood work will be patients will be identified only by number, so the identifying characteristics will not be available to the research staff. Again, we will be dealing with research professionals and healthcare professionals who are used to maintaining a good level of confidentiality. No identifying characteristics will be reported when the results of the study are reported. It will be a highly controlled research setting. Subjects will meet confidentially with researchers and physicians at UNE, and we will also be partnering with a lab who will be performing the blood draws and the establishing the results or measuring the laboratory analysis. The consent process will be that people will be informed of the entire procedure from the get-go. They will know what is expected from them. They will have the opportunity in advance to consult with their primary care physician, to consult with research staff, to ask any questions from the beginning, at any point throughout the study. They will certainly be able to withdraw from the study at any point. They will certainly know all of the risks and benefits from the get-go, and they will have the option to participate or not participate at their own free will. There will be no consequence for not participating in the study or choosing to withdraw at any time. Again, it's strictly voluntary. The risks and the benefits are actually fairly unknown. Patients will have their medication provided for them for the duration of their study, and they will also have their laboratory work done pretty consistently, so that is a benefit for some patients. However, they certainly, we don't know that patients will benefit better from chromium supplementation than they will from the drug use alone. So in that regard, we don't know the potential benefits to the actual subjects. We would probably say that they are very limited. So hopefully we are asking participants to accept the burden of the risks involved for the sake of the research. The risks include, and are not limited to, the risks normally associated with having work done in relation to measures for diabetic testing, including blood draws, irritation, and bruising or itching at the injection site, as well as periods of possibly dizziness or stomach discomfort with oral glucose tolerance tests, or the fasting associated. However, patients will be closely monitored here. Additionally, there have been some isolated incidents reported where there is a risk of liver or kidney damage that has been associated with long-term supplemental chromium use. So this risk will be discussed with the potential study participants. Additionally, there are some risks associated with the drugs, which will be outlined for the patients in consultation with a physician and in regard to the risks outlined by the drug manufacturers. This will be discussed with the patients. Of course, many of these patients may already be taking the sulfonylurea drug without any risks or side effects, so that will certainly be discussed as well. But overall, there is a small amount of risk with this, and there is a level of inconvenience with, of course, we all know the experience of going to have laboratory work done, the fasting and the waiting and the testing process. However, we hope that our subjects will feel that the burden they face will be worth the benefit of the research. There is a need for more work. There has been some criticism that indicates that there's no merit to this type of work if there's no measure of nurture. However, if we can find that chromium supplementation does work in a certain population, we don't really need to understand the precise measure of nurture to establish this. If it doesn't work, we will also have this information regardless of whether it's a measure of nurture or if the benefit is more pharmacological. And that is a key point here. As you can see, we are using a dosage of chromium that is much higher than the suggested adequate intake. So the benefit here may be pharmacological. However, is something that will be determined in examining this study upon its completion and the data in comparison to the other studies. Some of the existing trials, as I mentioned earlier, were too short to appropriately evaluate hemoglobin A1C. So again, there is need for more longer-term work, and there is a benefit to the work proposed here. The benefit of the research, too, will help to better define or clearly define the appropriate use, if any, of chromium and better assess the clinical relevance. It's fine to say that chromium may play a role in glucose management, that it may show some benefit, but this study, we hope, will allow us to precisely determine the benefits, whether these benefits are in matters of fasting glucose, whether they're benefits in matter of insulin sensitivity or something else, or if there is no benefit shown. Again, this will add to the existing data and help us better establish the inconsistencies of the earlier work. So I believe that concludes my discussion for today. If you have any questions, I certainly make myself available either now or anytime in the future. If there's anything at all you would like to explore further about this work, or any questions or concerns you have for me, I do make myself available. Thank you for your time here today.